Hi, I'm Dr. Matt Birch, and in this presentation I'm going to be talking to you about diabetic ketoacidosis. As you can see, these are the learning objectives for this presentation, and we're going to start by talking about the epidemiology. So 4% of people with type 1 diabetes experience diabetic ketoacidosis each year. 6% of DKA admissions are generally in those with a new diagnosis of type 1 diabetes, and 8% of cases actually occur as inpatients in patients who did not present with an initial presentation of DKA. DKA can also occur in those with type 2 diabetes, although HHS is far more common. Those with type 2 diabetes who are ketosis prone is most common in older, overweight and the non-white population with type 2 diabetes. So moving on to the pathophysiology of DKA, there's two main hormonal abnormalities, the first being an insulin deficiency and/or resistance, and the second being a glucagon excess. Now this contributes but is not essential for the development of DKA. This insulin deficiency enhances lipolysis from peripheral fat stores, releasing free fatty acids and glycerol, which promotes the ketogenic metabolic pathway. This is a brief, simple overview, as the full pathophysiology is outside the scope of this presentation. DKA usually rapidly develops over a 24-hour period or so. The hyperglycemia presents as polyuria and polydipsia, and as the ketones develop, nausea, vomiting, plus minus abdominal pain, which is present in about 46% of cases, and diarrhea start to develop. In the most severe cases, patients can present with altered mental state and coma. It's actually also worth noting that those with abdominal pain also correlate to the severity of the metabolic acidosis. When examining a DKA patient, you'll often find signs of volume depletion, such as decreased skin turgor, dry axilla, or dry oral mucosa. They are often tachycardic and hypotensive, and often these DKA episodes are precipitated by some other factor, so it's worth investigating or looking for those factors, which could be infection, other medications including steroids and thiazides for an example, or discontinuation of their current insulin medication. So to diagnose DKA, there are three criteria. The first is ketones, either serum ketones of 3 millimoles per litre or more, or urinary ketones of 2+ on a standard urinary dipstick, and a blood glucose or serum glucose of over 11 millimoles per litre, and a venous pH of less than 7.3, and or a bicarb concentration of less than 15 millimoles per litre. When investigating a patient with DKA, it's important to establish the serum glucose, get a urine dip with urinary ketones, and I've also included serum ketones next to that, a full blood count, user-knees, a VBG and or ABG, especially if the patient's hypoxic or has a very reduced bicarb. From this, it's important to work out the anion gap, and also consider ECG, chest x-ray, and if concerned about an underlying cause such as MI or pancreatitis or sepsis, to think about cardiac markers including troponin, amylase or blood cultures. Severe cases of DKA may require ITU admission for correction of their DKA. Severe DKA could be classed as a blood ketones of 6 millimoles per litre or more, a bicarb of less than 5 millimoles per litre, a V or ABG with a pH of less than 7, admission potassium of less than 3.5, a GCS of less than 12, desaturating, so less than 92% on air on admission, a systolic pressure of less than 90, or an anion gap of over 16. So now moving on to discuss the management of DKA, there's two broad categories. So the first is to correct fluid and electrolyte abnormalities, and the purpose of this is to expand the extracellular volume and stabilize any cardiovascular instability. This expansion of the extracellular volume aims to increase the responsiveness of insulin by lowering plasma osmolality, reducing vasoconstriction, and improving perfusion and increasing urinary losses. With regards to electrolytes, your main concern, or one of the main concerns, is the correction of potassium deficit, and we're going to be aiming for a target of about 4 to 5.5 millimoles per litre. The second mainstay of treatment is insulin therapy, and for the correction of a DKA, we typically use a fixed rate infusion of insulin, and we would dose that at 0.1 units per kilo per hour. So expanding on the management and the monitoring of treating the DKA patient, this can be split into various sections. So within the first hour, we'd want to be fluid resuscitating the patient, which can often be very aggressive, commence the fixed rate insulin infusion, and at the end of this first hour, we'd want him to be checking the CBG and the ketones and the potassium. At the end of this first hour, we also want to be reviewing the fluid regime based on the clinical and biochemical assessment, but it's unlikely that everything would have resolved in this first hour, and aggressive fluid management would need to continue for longer. So now looking at the treatment from hour 1 to hour 6. In this period of time, we're going to be wanting to looking at clearing the ketones and suppressing ketogenesis. For this, biochemically, we look for a fall in ketones of 0.5 millimoles per litre per hour, and a fall in the glucose of 3 millimoles per litre per hour, but also a rise in the bicarbonate level of 3 millimoles per litre per hour. And during this period, we're going to be continuing to monitor the potassium, keeping it within range of 4 to 5.5 millimoles per litre. So now moving to hour 6 to hours 12, we are going to be ensuring for a satisfactory clinical and biochemical improvement. We will be continuing the IV fluid replacement, we'll be continuing the insulin, and we would be continuing to treat any precipitating cause. We'd be paying particular attention to avoiding any hypoglycemia or hypokalemia, and also assessing for any complications of this treatment, which we'll come to at a later time in the presentation. So between 12 and 24 hours in the treatment window of a DKA patient, we would be expecting normalization of the clinical and biochemical picture. Resolution would be classed as ketones as less than 0.6 millimoles per litre and a venous pH of 7.3. I've put an asterisk next to that because it'd be worth noting at this point that hyperchloremic metabolic acidosis can often be present at this point because of the large volumes of normal saline that have been given. So a good surrogate marker for resolution and improvement of the keto acids in the blood is looking and measuring the anion gap. So the patient should move from a high anion gap metabolic acidosis to a normal anion gap metabolic acidosis. And would also be continuing to monitor for any other further complications of the treatment of DKA in this time period. So moving to complications, the two main complications with the treatment of DKA. The first being cerebral edema, which normally presents within about 24 hours of treatment. It normally presents with behavioural changes, urinary incontinence, but it can progress to abrupt neurological deterioration and result in coma. It's a very rare complication in adults. However, it does carry a high mortality rate across all age groups. The second main complication being non-cardiogenic pulmonary edema, again a very rare complication and is most common in the elderly population and normally occurs within a few hours of initiating this aggressive fluid therapy. So finally, discussing the prognosis of DKA, mortality rates generally tend to be low in developed countries, although prognosis tends to be worse with certain factors including age and the severity of the underlying pathology that precipitated the event, which for example could be MI or a septic picture. The leading causes of mortality in patients with DKA tend to be severe hypokalemia and ARDS. That concludes the presentation on DKA, and thank you for taking the time to watch. I hope you found it useful.